All right, we are going to transition to our third speaker. And great. So, Dr. Gonzalez Yeter, looks like if you can go ahead and turn on your camera and pull up your slides. Dr. Gonzalez is joining us also from Spokane. Hopefully, you also are in Spokane and did not make a drive early this morning across the state. And we are going to continue our theme of kind of the mimics and things that aren't what we quite expect on first diagnosis. So with that, beautiful, we can see your slides. I will turn it over to you.
Good morning. As you mentioned, my name is Tawny Gonzalez-Getter. I am actually tuning in from Coeur d'Alene, Idaho, where I live, so close to Spokane, but not too far.
And if I could ask a favor, the audio is very faint. Can you get a little closer to the microphone?
Are you able to hear me better now?
And maybe a little louder, and I hate to ask this, but maybe also shout a little bit.
Are you able to hear me now?
That's better. Thank you.
Okay, great. Um, as I was saying, my name is Tawny Gonzalez-Getter. I am actually joining from Coeur d'Alene, Idaho, so close to Spokane. So my case that I'm going to be discussing today highlights a rare but clinically relevant cause of chorea, and stroke is not the culprit. I have no financial or other relationships to disclose. So the case starts with a 50-year-old patient with type 2 diabetes mellitus who presented initially for 5 days of progressive left-sided involuntary movement. Her symptoms initially started as a burning, tingling sensation in the left upper extremity. So she initially presented to an outside emergency department, got a full workup there, was completely unremarkable. So she was sent home for primary care follow-up. Unfortunately, this patient did not have a primary care physician. So as symptoms progressed, she was up in our emergency department for evaluation and admission. Notably, she was not on any medications and had no other contact with the medical community aside from that ED visit. Her workup in our hospital was mostly remarkable for a significantly elevated serum glucose, very mild ketonuria, an elevated A1C, and most notably, almost constant left-sided choreiform movements without any other neurological dysfunction. When we typically hear of an acute onset of involuntary movements, one of the first things we're going to think about is stroke. As you can see from this figure, there's actually quite a large number of things that can cause choreiform type movements, immune disorders, metabolic dysfunction, rare genetic causes as well. In our patient's case, we were certainly thinking about stroke based on her presentation. So an MRI was obtained, which showed right basal ganglia T1 hyperintensity and T2 hypointensity. This is actually not consistent with a stroke. Typically, basal ganglia strokes show T2 hyperintensity with DWI changes. Regardless, neurology was consulted due to the abnormal movements. They reviewed her imaging, her workup, and overall history and determined that there actually wasn't a cause for any neurological conditions or any of the other concerns for chorea that I showed on the previous slide, with the exception of diabetic stereotopathy. So diabetic stereotopathy, as you can see, actually has a number of other names in the literature. It's actually quite rare. Estimated prevalence is less than 1 in 100,000, with fewer than 300 cases reported since 1980. But the most notable thing about this is it's actually the second most common cause of hemichorea and hemiplegia after basal ganglia stroke, and it is the leading metabolic cause. Typically, the presentation is an acute onset of unilateral chorea or bulismus. Patients are often older, although case reports of patients as young as 8 are certainly in literature. Usually patients have uncontrolled type 2 diabetes, although other types of diabetes can be implicated. And I think most concerningly, one meta-analysis showed that up to 22% of patients, this was actually their first time presenting with any type of diabetes diagnosis. Most often patients have a non-ketotic hyperglycemia, although this can occur in DKA as well as hypoglycemia. And as previously mentioned, there are striatal imaging abnormalities. It should be noted, however, that in the literature, 7% of patients had no imaging abnormalities, and therefore it's not considered necessary for diagnosis. We actually don't really know entirely what causes this particular condition. The proposed pathophysiologic theories, there's quite a few of them, There's two main buckets that are considered. First is metabolic dysfunction. The other is vascular abnormalities. Within each of these buckets, there's actually a number of sub-theories that are considered. The one that I will briefly discuss is probably the one that's considered the most likely, which is GABA and acetylcholine depletion. This diagram is essentially illustrating that the thought process is non-ketotic hyperglycemia will cause GABA acetylcholine depletion. And then basically that leads to regional energy loss, a metabolic acidosis state, and then from that, transient ischemia. Treatment, fortunately, is actually pretty straightforward, mainly consists of aggressive hyperglycemia management, although in some cases you will have to do some symptomatic management of the choreiform movements. In the literature, there is no difference between using insulin alone versus any other anti-hyperglycemic agent. And interestingly, there was a paper that recently came out that SGLT2 inhibitors are being considered as a treatment of choice because of the possibility of neuroprotection. Basically, this picture is illustrating the thought process behind why that would be the case. Of course, we are still looking into that because there is the concern that SGLT2s can accelerate neurodegeneration and, of course, cause euglycemic decay. Prognosis is actually pretty good. It's considered a transient condition for most people. Symptoms tend to persist anywhere between 5 and 6 months, and imaging abnormalities can actually improve between 3 and 8 months. That being said, there are some people who can have complications from it, including delayed improvement, persistent choreiform movements, or even recurrence after initial resolution. In our patient's case, she was started on basal insulin and metformin with almost immediate improvement in symptoms. She was discharged with primary care follow-up, and as of the most recent outpatient visit, had no residual choreiform movements and significant improvement in her A1C. My final thoughts from this case are essentially that increasing incidence of diabetes will likely lead to an increasing incidence of diabetic steatopathy, as well as other movement disorders that can be associated with diabetes. As such, we as clinicians need a high index of suspicion, especially when patients have an onset of hemiphilia and hemibolismus, and that would include for patients who do not have a prior diagnosis of diabetes. It also highlights the need for awareness that there are some pretty serious neurological complications that can come from diabetes. Here are my references, and thank you very much for listening.
Thank you. That was very interesting, and a case that, as the numbers would suggest, probably most of us have not seen before. So we have some questions coming in. So one of the questions, would you mind, I think the audio was a little bit not as strong when you were talking about the SGLT2s. So can you mention kind of what the thought behind the mechanism and also the risk too that might go with SGLT2s beyond the euglycemic DKA?
Sure. So essentially, the thought process is that this is a medication that can cross the blood-brain barrier. And in its just overall mechanism of action, it seems to actually induce ketogenesis. I kind of glossed over for sake of time, but essentially the thought process for why non-ketotic hyperglycemia seems to be the most common presentation is that without ketone bodies, GABA cannot be resynthesized. So in ketosis, you can actually resynthesize GABA. So in this case, the SGLT2, because it increases ketogenesis, the thought process is it's increasing GABA production and therefore reducing that risk of ischemia.
That's very interesting.
Sorry, I was just going to finish the reason that there's some concern is that there are some cases where SGLT2s can accelerate neurodegeneration for people. So we would want to make sure that that would not be a problem if we were going to use it to treat essentially a neurodegenerative type disorder.
That is really interesting physiology, going back to medical school for most of us. One other quick question. So why was insulin and metformin in particular chosen for treatment rather than, as you point out here, kind of there's some literature on SGLT2s or potentially other diabetic medications like GLP-1s may make sense here. As we've learned, they seem to be good for everything.
The metformin in this case is because this patient was not on any medications whatsoever. So I think the thought process was to sort of get her started on like standard basic treatment. Um, she also not somebody with a great amount of financial means, so trying to find something that would be cheap and easy for her to continue past hospital stay. As far as the insulin goes, that was mostly because of needing to like rapidly control her blood sugars. Based on her most recent report, she's no longer using insulin. She's just on like standard oral anti-glycemic. So that was more of an initial, let's get things under control so we can improve symptoms.
Mm, thank you. That was a great answer. Thank you. Very interesting case. You explained that really well. Just going to give a quick applause for all three of our presenters. We'll have another set of three in a little bit, and I'll turn it back over to Dr. Goulet.